our symposium, I'd like to introduce our next speaker, Gabrielle Eversole.
Thank you, Paula. Today I'll be sharing my research project on the clinical experiences of people with elevated lipoprotein A and the impact of this diagnosis on family and child screening practices. This project was born out of a curiosity given both mine and Ben Helm's personal experiences with lipoprotein A and our interest to learn more about this patient population. Overall, our study had some major goals to better understand the clinical experiences of people with elevated LPA, the impact of sharing this diagnosis with family, the testing practices of minors, how these clinical experiences may impact decision, regret, and anxiety, in addition to identifying barriers to testing and identifying what factors may be impacting this testing decision of minors. So overall, it has the potential to impact clinical care and inform clinical guidelines. By a raise of hands, I want to know who here has heard of lipoprotein A. Lovely, almost every single person in the audience that's in the room. I love to hear that, love to see it. So for those of you who don't know, lipoprotein A or LPA is a causal risk factor for cardiovascular disease, and it's 70 to 95% genetically determined. So this is an LDL molecule or particle, and this particle then has this apolipoprotein A component attached to it. So it has a similar but different properties than LDL itself, but is included in LDL levels when we're getting our LDL checked. Elevated LPA actually affects roughly 1 in 5 people worldwide, but most people are undiagnosed and don't know that they have this, because it's not part of the standard lipid screen. So it's not on your regular HDL, LDL, cholesterol, and triglycerides. It's a separate test. The phenotype of individuals with elevated LPA actually resembles those with familial hypercholesterolemia or FH. It's familial in nature, it's heritable. These individuals do have high LDL, and this high LDL isn't really able to respond to diet or exercise. So it's difficult to manage. In addition, these individuals do have often a family history of atherosclerotic cardiovascular disease. Oftentimes this is an early onset too in themselves or their family members, and this can result in the need for stents and heart attacks. Which leads to guidelines. Only recently have there been universal guidelines established in the United States. And Europe has had well-established guidelines that are universal for many years, and both now align within the last few months to recommend universal testing for adults. So when we started this project, that was not the case. But there still are no universal guidelines for children screening practices, which is important to keep in mind. There's also no targeted treatment for LPA, and the other options that are out there are limited and not targeted to LPA specifically. So we really don't know how to manage and treat this fully as well as we would like to. Additionally, the medical community and the general public actually perceive that clinicians have a limited knowledge and awareness about LPA. The Family Heart Foundation has quoted that only 1 in 6% of all clinicians in the US order half of all of the LPA tests. A lot of tests being ordered by so few providers. And additionally, there's been no research on the patient experiences or perspectives. So at this point, this is a very exploratory, descriptive study. And as a genetic counselor, of course, we're gonna look at some of these psychosocial aspects related to this. We know psychosocial health does impact cardiovascular disease risk. That is well established. Things like anxiety, depression, optimism are all factors that can impact our cardiovascular disease risk. So, given the lack of targeted treatment and these limited management options, we wanted to know if there was any decision regret from participants in knowing their LPA levels, which led us to 2 main research goals. Our first, describing this population and their clinical experiences. We don't really know what their perspectives are. And second, this came from the data that we actually collected, was to understand what impacts the testing practices of children. For our goal 1, there were 3 major aims, so describing what impact elevated LPA has on a participant, education experiences are from clinicians. So what are they learning about LPA? And describing what barriers are being experienced for our participants as well as their family members and children in the LPA testing scenario. How do we do that? So the first thing we did, we developed a red cap survey that was IRB reviewed and deemed exempt. We did have incentives for anyone who completed the entirety of the survey. That was optional. And our inclusion criteria included being 18 years or older, able to read English to complete the survey, and having a self-reported diagnosis of elevated LPA. We actually collaborated with the Family Heart Foundation in the design process of the survey and our project. And our collaborators were actually part of this patient population themselves, which allowed us to target and be very patient-centered with our survey and our practices. That collaboration also allowed us to use the Family Heart Foundation for recruitment. So we used their emailing list and their social media in order to recruit our participants. From their social media, they have over 7,000 followers. Not all of them have elevated LPA, of course. There are other things like FH, but we did have over 1,400 individuals open our survey link with 1,001 completed surveys. And we did have this sub-cohort for that goal 2 that I mentioned of 399 individuals that had children under the age of 18 at the time of testing that we'll get into a little bit later. So for goal 1, what were we looking at? What were the variables? So aim 1, which is describing this population and the LPA, is decision regret, anxiety, the sharing practices, how does LPA impact health behaviors, testing practices of our participants and the ordering practices, so who's ordering the LPA testing, as well as their self-reported LPA levels. Aim 2 about education was determining if education was occurring, who was educating these individuals, when was the education occurring, and the trust and optimism participants have regarding their clinicians and care. And last, aim 3 really was just the barriers, and these were all looked at using multiple choice questions, checkboxes, or Likert scales variably. But like I said, decision regret was one of the main things we wanted to look at. There is a decision regret scale that is a 5-point Likert scale, which originally has a 25-point scoring scale that you can then convert to a 100-point scale for ease of data analysis. We actually had some small sample sizes for some of those, so we reconverted it to a 10-point scale. And then for some analyses, we did categorize this into no, mild, or severe to moderate regret. But for this presentation, I'll be focusing on that 10-point scale. We also use the Generalized Anxiety Disorder GAD-7 scale, which is a 7-question 4-point Likert scale. And these scores are categorized in 4 categories, 0 to 4 being minimal anxiety, 5 to 9 mild, 10 to 14 moderate, and 15 to 21 severe. Additionally, we did explore what other variables were associated with testing children's LPA. So this is that goal 2. We did descriptive statistics, some chi-square tests, and a multivariable logistic regression. What did we find? Like I mentioned, this is primarily descriptive. We're describing this population. So starting with our demographics, it was primarily female individuals, as well as primarily white individuals as well. Similarly to Rita's, actually, we had a very high percentage of individuals, a majority of our participants had at least a bachelor's degree or higher. And their pre-tax household income was also $80,000 or higher as well for a majority of our individuals. So did skew towards higher education and higher income. We also asked, did these individuals know about their LPA testing before they had their blood drawn? And almost 26% of them did not know that they were getting their LPA tested before they had their blood drawn. A majority of the ordering clinicians were cardiology clinicians and primary care clinicians, as we expected. Interestingly, LPA is actually measured in 2 different ways. There's 2 different scales and units, and so we had to categorize them and combine them, but there were some individuals who didn't know their units for their testing, so this sample size is a little bit smaller, but our data really skewed towards moderate, high, or very high individuals for their LPA level risk. So something to keep in mind as well. Overall, 90% of individuals were not referred to a genetic counselor for LPA specifically, which is not surprising. But there was 34% of individuals that had a self-reported clinical FH diagnosis. And of those 34%, 29% of them did complete genetic testing, with almost 62% of them having put positive genetic testing. Still means there's about 38% that didn't test positive on genetic testing, but they have elevated LPA, which might be the reason why they're having these high cholesterol levels. Additionally, there is a known association of LPA with coronary vascular disease, which aligns with what we saw in our population. So we asked about cardiac events, and we were seeing them. So it maybe not as high of a percentage as we expected, but we were still seeing some of these cardiac events in our population. Additionally, only 63% of individuals had a family history of early onset cardiovascular disease. So there's almost 30% of individuals that would have been missed if we were only basing things off of family screening itself. And 20% of individuals were not on any sort of cholesterol lowering medication to try to manage their cholesterol levels. So something that one of my committee members was found very interesting from a clinical perspective. Additionally, over 61% of individuals did not receive any LPA education at all from a clinician. So overall, these individuals likely had to do some self-study and find other resources. Of those that did get testing, a majority of individuals did have their education after the testing was completed and they were found to have the elevated levels. But even though a majority of people didn't receive education, almost 93% of individuals were sharing their results with their family. So they had some sort of understanding about the importance of LPA and the hereditable and familial factor of this. Like I mentioned, we also looked at optimism. So optimism about their current clinical care and optimism about future treatment options. So with current clinical care, there was a majority of individuals had not at all or very little optimism. And then about future treatment options, that shifted, and it's somewhat to very much optimistic about the future treatment options for a majority of participants. Similarly, we looked at trust in the knowledge of their ordering healthcare clinician and trust in the knowledge of their current healthcare clinician. So overall, we see that people were very trusting about their knowledge of their clinicians, with being it somewhat or very much. We did ask the difference because some participants were being cared for by a person who was no longer, or who didn't order their LPA testing originally. We also asked if they trusted their clinician with their LPA management, and we see that same trend. So overall, this patient population is very trusting of their clinicians. That AIM-3, asking about barriers, 47% of individuals did experience a barrier to getting their LPA tested, so almost half. And of this, the most common barrier was an acknowledged or perceived lack of clinician familiarity or knowledge. So that's important to keep in mind as well, as this is the biggest barrier individuals were experiencing. Touching on decision regret. So overall, this is the 10-point scale. So 1 is equal to no regret. And at about 3.5 is where the moderate to severe regret starts. When we ended up categorizing it. So overall, over 80% of participants had no to mild decision regret, and we're in that lower category. We also looked to see if there were any other factors that might be associated with decision regret that we had looked at, and we didn't find anything that was statistically significant. Similarly with anxiety, almost 72% of individuals had minimal anxiety regarding their LPA. And we also looked to see, were there any factors that were associated with these anxiety levels, and nothing was statistically significant in the overall cohort. Not what we were expecting to find, but it's what we found, which led us to our sub-cohort analysis. So this is our goal 2. No one's explored trial testing practices, and so since we had enough data, we wanted to investigate this further. So like I mentioned earlier, 1,001 completed surveys and 399 individuals in this parent sub-cohort. Additionally, 144 of these parents did end up testing their child or their children's LPA levels while they were under the age of 18. Similarly, the largest barrier for children's testing was also an acknowledged or perceived lack of clinician knowledge and familiarity. So we're seeing a trend throughout that clinician familiarity and knowledge might be one of the biggest barriers. We also asked if specifically the lack of targeted treatment influenced their testing decision making process, and 41% said it did not affect their decision making process at all. However, we did want to specifically ask about some specific factors. So we asked all parents if these questions about factors that would influence them not to test their children. So as a select all that apply, this pink column is the parents who did not test their children and how many of them checked each of these boxes as a reason that played into their decision-making process. But also the blue box is those parents who did end up testing their children, but still selected these reasons as factors that were swaying them not to test their children. So their family doctor not recommending it at this time indicated that parents were 4 times more likely to not test their child if they selected this reason. Wanting their children to decide if they wanted to be tested when they were older, so that autonomy piece, if this was selected, parents were 3 times more likely to not test their children. Being unsure about how useful this information would be for their children indicated parents were 2 times more likely to not test their child. But being worried that their children would also have elevated LPA, this was actually a higher percentage in those who did end up testing their children, but still selected this. So maybe this is something that's actually influencing them to test their child instead of not. And similarly, being concerned about there not being treatment options for children with elevated LPA, there was roughly equal percentages, not anything statistically significant, which is not what we expected. We expected the lack of treatment options to be one of the biggest drivers in this decision-making process, but it wasn't. So on the other side, we looked at those factors that might be influencing parents to test their children. So same setup here, but overall, there was a 20 to 30% increased prevalence of these reasons in participants who did end up testing their children. So wanting to know if their child does or does not have elevated LPA, wanting to prepare their child for long-term management needs because of their elevated LPA, wanting children to consider treatment for other related heart disease risks to mitigate their risk, as well as qualifying for clinical trials and medications later on, as those are in process right now, as well as just parents finding this information useful for themselves. Which we also, we didn't want to stop there. We wanted to look to see if there were any other factors that we had asked about in our survey that could be impacting this decision-making process. Overall, there's a lot of different factors here. So this is leading into our multivariable logistic regression. We looked at family history, clinical history. Did they have a personal clinical event? Trust, anxiety, LPA levels, education, age, optimism, all of those things. And most of these were not significant. Not what we expected. We expected that if there was a family history of early onset heart disease, that might be impacting this decision-making process, as well as having a personal history of a clinical event. Those are things that we thought were going to be significant and weren't. The factors that are in red on the screen, those are what were actually somewhat significant and played into this decision-making process in some way. Overall, there's a lot of numbers on here, but age, as our patients and our parents were aging, they were actually less likely to test their children. So that's the trend we are seeing there, as well as as their optimism increases about their current clinical care, parents were more likely to test their child. Having a genetic counseling referral, just not even if they've met with a genetic counselor, but the referral itself, there was an increased likelihood to test, but this was a small sample size, so we have to keep that in mind as well. And then looking at FH and decision regret, you can see FH is not statistically significant. Decision regret was, But there was actually an interesting interaction between decision regret and having a clinical diagnosis of FH. So instead of looking at them separately, we look at that interaction, and that was statistically significant. Which leads to this model. So based on our model, we can determine the predicted probability of parents testing their children, and it found this interaction. So when decision regret is low, so at that 0 to 1, low or no decision regret, there's about a 40% chance or probability of parents testing their children. The red line is actually individuals who did have a clinical FH diagnosis, and we see this as uniform. So there is no difference as decision regret increases, because that's along the bottom. So as decision regret increases, their likelihood stays the same to test their child. So our decision regret in people who have FH does not seem to be impacting the decision-making process for their children. But in individuals who do not have a clinical FH diagnosis, so that's this blue line, as their decision regret increases, the likelihood to test their children decreases. So a very interesting interaction, definitely needs a little bit more research here to fully understand. But overall, we can see that people with decision regret are behaving differently depending on a clinical FH diagnosis. So in summary, our main key findings are that a majority of participants were not educated about the importance of LPA. Additionally, there's at least a perceived or acknowledged lack of clinician familiarity with LPA that's seemingly impacting these participants. And decision regret is not influencing parents testing their children's LPA in the context of being told they have FH. So important things to keep in mind, especially with a dual diagnosis or lack thereof. Like I mentioned earlier, this is the first study describing the testing practices, clinical experiences, and the family screening process. We focused, on barriers. That was one of our aims. And as a reminder, 1 in 5 people have elevated LPA, but most are going undiagnosed. So are these barriers? Over almost half of our population and our participants experienced a barrier to testing. They all did get testing, but it was a barrier. So are these barriers playing into why most of these individuals are going undiagnosed? It could be. With that lack or the perceived lack or the acknowledged lack of familiarity and knowledge from clinicians is the biggest barrier that we saw. And so is it that our education needs to improve? So clinicians are not aware of this. They don't know about it. They aren't familiar with the utility or the management guidelines for LPA. And so it shows this need for further education. Additionally, we looked at that optimism, right? And that was playing into our parent decision-making process. We know optimism is associated with better cardiovascular health outcomes, and we were seeing a difference between optimism with current clinical care and future treatment options. And that's what we expected, but also we were seeing that there were people who were more optimistic were also more likely to test their children's LPA as well. So given the lack of current targeted therapies and the perceived lack of clinician knowledge, we did expect to see that difference between current clinical care and the future treatment options, given that that is where we're at right now, and we are seeing that this influences LPA testing in children as well. Like I mentioned, this is also the first study exploring the decision-making process for LPA testing in children. This has not been explored ever. And so this is showing that even if a parent has regret about getting their own LPA tested, they're still seeing this knowledge be beneficial for their children. And so it's important to keep that in mind as well. And we saw this theme throughout, that knowledge is power. And so even just knowing about this allowed parents to find some sort of utility in this information. Also, it highlights that there is this familial aspect and this heritable aspect to LPA that might be important to stress to families, not just as genetic counselors when we do interact with these individuals, but also for all clinicians as they're interacting and testing for this as well. Which leads me to my strengths. Overall, we had a very large sample size. 1001 is more than what most people in the cohort would expect to get. It also provides a very nice basis for future research options because this is the first. This is an exploratory study. It's descriptive. There were a lot of variables that we looked at and a lot of novel variables and novel results that we got that do warrant further investigation. In addition, using a survey-based tool is helpful. It's a strength in some ways because it allows us to reach a broader amount of people. Limitations, though, do include social media recruitment. So social media recruitment is known to skew towards health information seekers, especially those involved in a foundation of some sort. We did have a fairly homogeneous population, similarly, and that survey-based tool can also be a limitation as well because we're not able to get the depth like we would with a qualitative interview or something like that. Additionally, we did have some smaller samples sizes for some of our sub-cohort analyses, so that did limit things a little bit because we were such a broad descriptive study that tailoring it down would be important for future research. So overall, exploring different populations is what we need in the future. So looking at adolescents, people who were tested as children, parents of people who did or didn't test their children specifically and focusing on that, as well as getting the clinician perspective, right? That's important here because this is not something that's been looked at. And so getting that clinician experience would be important as well. Getting broader and larger sample, that's always something we all want for all of our research, as well as doing that qualitative research to get into those deep themes of what's the why behind what's going on, as well as looking at clinical and personal utility more specifically for our LPA results in this population. In summary, what are the clinical implications of this? So it provides insight on these patient experiences that we can utilize in the clinic, as well as it does support a need for improvement in clinician education and awareness of LPA across the board, given that that's the largest barrier, and we know most individuals are undiagnosed, so it needs to be addressed. And lastly is that the universal or standardized testing guidelines should at least be considered and discussed for children, given that right now family history is really all they go on for that. And that was not found to be significant in the testing decision making and the probability of testing a child. So that's important to keep in mind as well. Overall, I wanted to acknowledge my amazing mentor and chair, Dr. Ben Helm, for all of his support. This project would not exist without him, as well as my amazing committee members, Dr. Julie Clary, Sarah Fitzgerald-Butt, and Dr. Colin Halverson for all of their support and helping me get through the program and the research project in general and the publication piece. I also wanted to acknowledge Mackenzie Ains and Isabel Bryan. They were previously of the FH Foundation that helped with this collaboration and the getting the study off the ground. Also the Department of Medical and Molecular Genetics for funding for my incentives, as well as program leadership, Paula and Missy, for all of your support and for being a listening ear when I needed it. And then last but not least, my amazing classmates, my partner who is here today, my family, and my friends who are listening. I appreciate all of you guys being a sounding board, and this program wouldn't have been the same without all of you. Are there any questions? No questions? No questions online. I'm not seeing any online either, but thank you guys.